With respect to how to pick the frontline therapy, there is no right answer, but typically what we have learned so far is that triplets seem to do better than doublets. And we've been doing that for a while, but the SWOG 777 study supports the use of VRD over RD based on response rate, PFS, and OS. So I think that's been established. That was without an intent to transplant. So I think that a lot of patients and community doctors in the US are already using. Carfilzomib Lendex has also been used frontline. Probably we use it and think about it more for high-risk patients, particularly those who are young without cardiac issues. And of course, the question out there is how will the addition of monoclonal antibodies, particularly daratumumab, up front, lead to these improvements or changes in frontline therapy. And we already have an example of DARA-VMP, the Alcyon study showing improvement in PFS and response rate with the addition of DARA to VMP. But I think data are eagerly awaited from the Griffin study where VRD plus minus DARA randomization should be reading out shortly to guide that new therapy. In terms of how the frontline therapy affects subsequent therapies, I think it's important to distinguish, and there's a lot of concern that using too many drugs up front might compromise later outcomes, but we have to remember that when we start with 3 or perhaps in the future 4 drugs, it doesn't mean that each one of those drugs is being used till progression. We do an initial debulking, and then we consider transplant as a consolidation for those who are eligible, and then whether they're transplant eligible or not, eventually you're going to minimize the therapy and pick 1, perhaps 2 drugs, depending on the patient's risk profile, to maintain. So I think that should alleviate a lot of concern that you're not using 3 to 4 drugs forever, and you're not going to then breed resistance to all of the drugs, just the 1 or 2 that would be used to maintain the remission.
I think, the question around the role of transplantation in the management of patients in 2018 is an important one. And I think for patients who are fit, and I don't use an age cutoff to make that distinction, collection of stem cells following 4 cycles of induction, followed by transplantation and first remission does remain the standard. I think that there's a lot of data evaluating potentially delaying or eliminating the use of transplant. But it's important to remember that in every trial that has tested great induction X plus transplant versus great induction X without a transplant, the duration of remission is longer, even in the transplant group. So I think, at least with available data, transplant does remain an important goal. If one's going to think about a transplant, usually we typically want to collect cells after cycle 4. You don't have to use that as an absolute limit, but the more therapy, particularly with lenalidomide, that a patient has, the more difficult it may be to collect stem cells. So typically we like to collect after 4, and then usually we go to transplant after 4 cycles. We may give an additional cycle or 2, depending on the response. I think the maintenance question is an important one to handle in a number of different settings. It's clear that in the post-transplant setting, lenalidomide maintenance has become the standard based on large randomized trials. I will tell you that I think that len maintenance is effective except in the high-risk subset of patients. And our group has data suggesting that for the 414, bortezomib or proteasome inhibitor-based maintenance is probably better, and that in truly high risk, 17P, combination maintenance therapy probably is a standard recommendation. And our group, as well as groups in Minnesota at Mayo, as well as other groups, have recommended a risk-adapted maintenance strategy. For non-transplant eligible, lenalidomide does have good data, and there is emerging data on the use of proteasome inhibitors as well. Emerging agents such as ixazomib, there is some data on bortezomib. There may also be additional data coming very soon on the use of antibodies such as daratumumab and elotuzumab that may also be useful in the non-transplant eligible patient.
Early versus late response generally matters. Early responders are, for the most part, more likely to achieve deeper, longer response, although it is variable and it may potentially be affected by other factors, including biology of the disease. Still, there is a sense that earlier responders seem to be having generally longer remissions. But I would like to also emphasize that I have observed, and it is established as phenomenon, that Some subsets of myeloma have consistent, ongoing, and deepening response over time, and those who respond later will eventually be also having potentially as good outcome those early responders. In some of the studies which I conducted, we have done analysis to see whether there is any difference in outcome, and we have not seen dramatic difference in those type of correlations.